I was assigned female at birth. I have a non-binary gender identity, so I feel I'm neither male nor female. When I was explaining that I'm transgender and that I'm not female, she was like, well, endometriosis is a female disease.
He was dismissing my endo as severe pain.
If you feel like you're in pain, just go to a doctor, and if the doctor doesn't believe you, go to another doctor.
And they said wasn't there anything they could do without surgery and that I should just keep taking pain relief.
And the next doctor?
The same thing.
And the next doctor?
The same thing.
7 years.
7 years.
He told me that it was just bad period. A lot of doctors telling me it's all in your head, there's nothing wrong, it's normal.
I've gone through 2 miscarriages, maybe I have not had proper way of grieving. When I spoke to my GP, she didn't really help me with this.
The doctors don't ask. No one has taken the time to really ask Indy what she's going through. No one.
The best things doctors can do is just to listen.
Well, it's always difficult to come as the GP after hearing the sad stories that people experience, but unfortunately I know that's your reality, and I hope that working with you we can actually try and address how we can improve the care for people who suffer from not just endometriosis but all other illnesses. I thought I'd start by talking about what is primary care, what's its role, and I'll just sort of set a story for my vision for general practice and certainly for the care that I believe everybody has a right to. And so the definition internationally is about it being the first point of contact for people in the healthcare system. And from my perspective, it's a foundational, really important part of how our healthcare system works. And interestingly, that nations who have a foundation of primary healthcare certainly have better health outcomes. The sort of international global health and World Health Organization aims and goals for healthcare, and more specifically primary healthcare, is about looking at how can we actually improve patient experience of care. And that includes the quality of care that you're receiving and the satisfaction that you feel about the care that you receive. Improving actually the health of the population overall and reducing the cost. And that's fairly poignant to me at the moment because certainly 12 months ago with the budget, primary health care was completely attacked by budgetary changes which weren't anything to do with the quality of care that we were receiving. They were all about a financial bottom line. And all of this sort of economic rationalisation was not about the care that you or I get or the care that I deliver. It was just about, we're worried about expense. Primary health care takes a lot of money, so let's just cut it. Does that make sense? Is the cost of primary health care actually worth cutting away? My argument is that it's the first place you don't cut care costs. It's actually the place you put the increase in cost. There's fantastic research out there about the centrality and importance of good primary health care. The United States is a really good place to look at healthcare because I think they've got the worst healthcare system in the world, but I also think they've got the best healthcare system in the world. And how does that work? That works because every state in America, and they've got, 51 or 52 states, each state runs their own healthcare system. They have an overriding sort of value system, but actually every state works differently. And fascinatingly enough, a lot of the states had no primary health care as part of their sort of mission for health. So I, as a patient, if I thought I had a gynecological issue, I would go and see a gynecologist. So if I thought I had endometriosis, I'd go and see the gynecologist. If they said no, that wasn't what I had, I would go home and I'd go, okay, they've said no, who do I go to next? And so I would think about who I would go to next, and I would then go off and see the next specialist, and then I'd go and see the next specialist, and I'd see no one was actually directing me, no one was helping me understand what was going on, or actually giving a sort of a whole of health perspective. And this woman called Barbara Starfield did a fascinating audit of the health outcomes in America, the states that had a primary health care system, not only did they have actually better healthcare outcomes, so they actually had better health overall in those states, they actually had much cheaper healthcare. And that makes sense, because if you're not actually having to go off and see 100 people to find the right person to see you, it's actually going to be cheaper. But also, if you don't have a coordinated care system, then you're also going to be generating more expense, and that's of no benefit to anybody. So my vision for healthcare is very much reflected in what's been spoken about by our previous speakers. It's about a patient-centred medical home, and it's terminology that some people like that name, some people don't, but I'm going to use that name just because it is an internationally sort of used term at the moment, and so if people are interested, they can actually go and have a look a little bit more. But essentially, there's a big groundswell because of this more and more evidence coming out about the fact that if we have a really good primary care system that's focused on you, the person at the centre, that coordinates your care, is comprehensive, is accessible, and is committed to quality and safety, then you actually have much better health. Now, that's not going to mean that you go to someone and you definitely get listened to, like the stories we heard. We obviously need to find the right doctor to hear your story, but at least if we have a theoretical basis about why we should be finding a GP who looks after us. What does that mean to me? I mean, it sounds theoretical, so it does mean, as far as I'm concerned, that we try and make sure by having one place that you see as your medical home, who you go and have one healthcare record with, then that should mean that you have an enhanced access to appropriate care. The practice knows you, they've got your records, they can make sure that things get coordinated. There's that continuity of care. Them being able to see your story, see what's been investigated, see who you've seen, go through with you about what it has or hasn't worked, and sort of start to try and put the pieces of the puzzle together, because things can be difficult. I think Cherry really nicely put it, is that she has a lot of patients who've got constipation who don't have endometriosis. She's got a lot of patients with diarrhoea who don't have endometriosis. It's about putting it in, hearing the story and deciding that the story together makes, you know, your story says this. And sometimes your story is your story, and it still takes us a while to actually get to the bottom of what's actually going on. A good medical home is going to actually help provide support for self-care, to actually access you to things like this particular conference, to be able to get you to understand or increase your levels of what I call health literacy. So in other words, when a doctor tells you something, what does that mean? How do I access more information about it? We're really bad as healthcare providers sometimes of giving you terms that is my everyday language, but isn't your everyday language. And so, you know, I think we know that, but it doesn't always mean that we remember. And also sometimes, you know, you're sitting there with the doctor and you're nodding in agreement, but actually you're not understanding. Not everything goes in, and it's really hard. You feel overwhelmed by the information that you're given. What do you ask about? What don't you ask about? And sometimes that takes time, and being able to sort of just go back, let it diffuse, go back, ask more questions, etc. But having one place, again, hopefully, will assist in that, coordinate your care. We need to plan for the best primary health care that we can do. Again, from my perspective, that's about understanding that from where I sit about running a practice, I've essentially got 4 types of healthcare I need to actually make sure I cover. So that's the really important preventive healthcare. It's about managing the exacerbations and acute presentations of things. It's about managing chronic disease, and it's about being able to provide appropriate palliative care. And I think, you know, there are things that are going to sort of move in and out of obviously mostly 3 of those things for some people, and finally the 4th. So how does that work with endometriosis? Where does that sit for us when we're actually using that as a model of care? Remembering that my focus as a GP is always about you as the patient, okay? It's not about you as the pelvis, it's not about you as the diagnosis of endometriosis. And I'll take that back a little bit. When I was taught as a medical student, it was all about diseases. So I was being taught about endometriosis, and that was the framework in which I was taught. I'm very much of a different model of care, which is about, here's your story and these are the things that are happening for you, and this disease, endometriosis, is affecting you in this way. What are the things we need to do to manage it appropriately? So when you present to the GP, from my perspective, it's about trying to make sure that we get the right history. And again, we saw those stories where the history wasn't well listened to or received. And so that's a responsibility of the GP, but it's also our responsibility as the patient, trying to make sure that we think about before maybe you go about, I mean, I've got people who come in and they've written it all down for me and they've got the whole scenario there to make sure they don't forget. And that's not a bad way to actually start, because you know when you get nervous, you're going to forget to say some really important things. And that's really good, and it helps put the whole story into the right place. It's about understanding the role of appropriate examination and investigations. Now, from my perspective, that doesn't mean that we immediately need to send off for to go and see a specialist, because that's going to depend upon the story that you have and what you want to do about it. But it's about you knowing what your options are. What do I think's going on? What do you think's going on? Let's make sure that we're actually, you know, of the same understanding, and then making sure that everything that then proceeds is the right thing for you, and you know what we need to access. So again, I think that this slide sort of tries to go through that. Now, I've put there about accessing health pathways. One of the things that I've had the pleasure to be involved with over the last sort of 18 months to 2 years is the development of a website called Health Pathways Sydney, which is about GPs working with our local specialists and sort of service providers to actually improve the GP's knowledge of what services are out there. One of the big issues, you know, you saw that big long list that Melissa talked about all the different people that can be involved in your care. You know, there was literally sort of 8 to 10, and there was someone else saying, well, how do I find that right person? Well, can I tell you, I have the same issue as the GP. Not only is it hard to keep track of where the services are, who are the people who are interested in it, what's the right way to get there, what tests do somebody absolutely want to have before they assess you. And I need to know that not just about endometriosis, I need to know it about an awful lot of things. And so what we've been developing is this fantastic website that assists GPs to make sure that your journey for your illness, of what it is that we're trying to find out, is the most appropriately managed, but also what are the local services that I can access. So this one, it's too small for you to see, but if I went back to that previous slide, that was sort of like the front page that the doctors get to see, and there's an awful lot of sort of different illnesses. But if you go into women's health and then you go down into women's health, you can actually end up coming out with endometriosis. And so this particular one of it is about endometriosis. It's not what we call localised at the moment. At the moment, it's just this is what GPs can do, but it's still really useful. So if you see a GP in my area, they can at least go to this and make sure that they have covered all the things that would be expected to cover off and advise in terms of treatment pathways. So I suppose that's sort of a reassurance for you to know that that's work that we're doing as doctors to try and make sure that the service access is there and appropriate. So again, it was just sort of reiterating here about your role in the story. It's about trying to make sure you really bring your story and your concerns. Make sure you do feel listened to and validated, and if you don't, then it's okay to go and find somewhere else. But what's really good is when you find that somewhere else that does listen to you and does make sure that you're cared for, please make it your home. Understand that importance of actually having that one record, having the ability for the GP to coordinate that care. When there's 10 people that you're seeing, that we have it all written down, we can actually access more Medicare items too, if we can then draw up a thing called a management plan that then can access you to some physio visits and or an exercise physiologist. Not much, you get 5 extra visits per year that fund that type of service, But it's really worth it if, you know, because of your endometriosis, the cost of your care just starts building up and becomes difficult to access. And I suppose that's one of my biggest battles, is trying to make sure that my patients who can't afford it can actually access the appropriate care, which is why I really need to know what services my local hospital has so that I can access that clinic, find out who's there, make sure that the access to it's as quick as possible so that it is about timely access. And the things I want you to ask is, well, if you're sending me off for this test, why am I having this test? What actual information is this test giving you that's going to make a difference to the care that I have? And more to the point, make a difference to the symptoms that I'm suffering and the quality of life that I'm experiencing. Just as an aside, it was quite interesting. As part of this, I had a look at my practice to see how many patients we have with endometriosis. So the way our database at my practice is set up, I can do searches for patients that I call active patients. So in other words, an active patient for my practice is someone who's been 3 times in the last 2 years. And so we've got 8,900 and something patients who access our practice on that basis. And so I did a search for how many patients have a diagnosis or been to see us for endometriosis, and that was 195. And I thought, gosh, 195 is really low. And then I realised that's really stupid, Charlotte. The 8,900 is actually men and women, and it's all age groups. So if we actually then start doing a shift down, how many of my patients actually are in an age group that would have a diagnosis of endometriosis, because it's a bit stupid saying, well, I need 10% of men who are in their 80s to have endometriosis as well. 195 was spot on, perfect. So that really reassured me that at least I'm in the right ballpark for us having the diagnoses made. Am I in the right ballpark for trying to make sure that those patients are accessing appropriate care? Well, I probably need to do an audit of my records, but at least I know I've got 195 patients now. I can pull out those files and I can go back and have a look. What are their stories? What have they come in telling us about that I have or I haven't listened to? The story that always sticks with me about an endometriosis patient was when I was very young in general practice. I had this particular woman come to me, and she had a lesion in her belly button, and it had been growing, and she didn't know what it was and I didn't know what it was, so we did a biopsy, and it was an endometrioma in her umbilicus. It was like, whoa. So she had a laparoscopy. She was riddled with endometriosis. But she had never, ever complained about her period pain to us as a GP, because she had that framework that was her story. She had severe period pain. It had started from pretty much her first period, and that was her life. So she didn't know that she should even tell me that was something that was part of her story. And it was just wonderful that for her, the treatment of that illness did make a huge difference to the quality of her life. But we hadn't found it because she had a lesion in her umbilicus. And I doubt that I will ever see that again. But, you know, that was a really good lesson to me about making sure that I did ask women, what are your periods like? How much pain do you get? How heavy are they? Which again goes back to one of the patients who said her GP never asked her what it's like, what is her experience. But really, you know, keep us accountable. That's what we're there for, and we are to try and make sure that the journey that you experience is appropriate, timely, and more to the point, tailored to your needs, not to my needs, not to the specialist's needs, and not to somebody out there telling you what you should be doing or how you should be responding. It's about you at the end of the day, and how you affect other people, obviously, in your family with your illness.